patient, the most ideal time is 7 to 10 days, 7 or 5 to 7 days after your menstrual period. Why did we say that time frame? Correct. The breast will be tender. It's the most accurate time without that fluid influence, without that hormonal where things start to feel lumpy, sometime before menstrual period. Absolutely. You do not need to know all of these steps of the breast self-exam. Don't mix up breast self-exam with clinical breast exam. How often do we do breast self-exam? Once a month. How often do we do clinical breast exams? Once a year, correct. So keywords are important when you go to review material. If the patient is no longer having menstrual periods, we say just pick a day of the month and that works for you. First day of the month, every month. Palpating, feeling for skin changes, lumps, things like that. Mammograms, we already discussed those. Yes, if you're considered to be high risk, the recommendation typically is 5 to 10 years sooner than the normal. And oftentimes that will be an MRI versus a mammogram. But you have the whole insurance system, the whole thing, the whole documentation of yes, you're at high risk because of these factors, all of those things that go into that.
So, at age 55, you decide to go yearly or research.
Correct.
The book you say you can shift to 2 years in the book, as it says.
Correct. So, and that a lot of times depends on your healthcare provider and your past history and all the rest of that stuff. I think you can wait 2 years now since you're this age frame or not. So, is there anything in the history that would warrant you to recommend it sooner than that? You as a student won't have to decide that part. I won't give you somebody that's 56 and then you're like, you're every 2 years.
So, next is do that, it's not the healthcare provider who has that.
Who decides that?
Yes.
The healthcare provider, like clearly. Would say, well, you've been in good health for all these years, you've not had any issues all along, and you're 57, so you can probably actually just slow down and take a mammogram every 2 years versus every year. There's lots of different ways that we do mammograms. Breast biopsies, same things we've been talking about. Taking care of the site following your biopsy exam procedure. Ice or heat helps sometimes. Sometimes it feels, it's a little bit painful and it punctures the pull that as pull out some breast tissue. Bleeding and edema, we're a good supportive bra on that site so it heals well. And by the way, numbness may be expected because we did do a surgical procedure, so don't get too concerned if it stays numb for a couple of weeks. There's lots of ways we do biopsies depending on how much tissue that they feel like needs to be obtained. Clear nipple discharge is oftentimes normal. It's usually normal, sometimes it's bilateral. We get more concerned when it's been persistent. If it's unilateral, one breast versus both. If a patient reports breast pain, is very seldom indicative of cancer. Usually it's muscular in nature of some type and other reasons versus them getting worried that it's cancerous. Fibrocystic breast condition was what I was talking about before lunch. That's fluid-filled cysts within the breast. It causes enlarged breast, painful, tender, because of that fluid in there. As I said, definitely recommend them not having their mammogram done around the time of their menstrual periods because that fluid fill is going to be more filled then because of the hormones. At this point in time, what the research shows, there is no correlation between a patient having this condition and them having breast cancer. No correlation at this time. Again, a lot of these conditions worsen before the menstrual periods each month because of that hormonal influx. Your patient says, gosh, my breast was so tender and full right before. Well, that just goes with the territory. That's just not something that we need to get real concerned about. That's just the way that the hormones go. And as was the case with the story that I told you about, a lot of times we want to evaluate that. We want to do an ultrasound to make sure it actually is fluid-filled cyst and not some cancerous tumor. Fibroadenoma is just a little benign tumor. Non-tender, movable, benign. Again, with patients, I do not use benign and tumor in the same word, in the same sentence. Because tumor means to the community people that aren't medical, that probably means cancer. It's a benign finding. Yes, it's a little lump, it's just round. It's not cancerous, it's not cancerous. Hyperplasia, as we discussed earlier, atypical cells acting in an atypical way. We definitely need to evaluate that, treat that we'll definitely talk about treatment of that because of the increased risk of those cells changing over into breast cancer cells. Okay, this one's important to know. This one is an abnormal tissue growth. It is not cancer. It is not cancer. However, there's a 4 to 10 times risk that's going to change into cancer cells. So we'll monitor it. We'll definitely talk about chemo prevention for this one. No, you've been diagnosed with LCIS, which is abnormal tissue growth in the lobules. It is not cancer. However, we're going to probably talk about chemo prevention meds of some sort because we don't want it changing over into cancer cells. And we're going to keep a close eye on that. Breast cancer overview. When we talk about invasive breast cancer, that means that it penetrates the tissue, the surrounding tissue. DCIS, the last one was LCIS, that I said was not cancerous. DCIS is cancer. It is non-invasive. It's not metastasized. It's non-invasive. Obviously, the prognosis is much better because it's localized. And oftentimes, treatment recommendation is radiation. We do need to treat this. Yes, I said it's non-invasive, but it is breast cancer, and we do need to treat it because we don't want it to metastasize. So we're going to be pretty aggressive with the treatment of this one. That's different than this one. This one's invasive breast cancer. As you can see, there's lots of types. You don't need to know all of those. You do need to know cancer risk factors.
You said you don't need to know all.
You don't need to know all the different types because it's not. As you can imagine, they can evolve from lots and lots of places within the breast. Like you don't need to know the relative risk there. You do need to know breast cancer risk factors. We talked about some of them already. Add them up. If you're given 4 females, which one has the most risk factors? Just tally them up. Some of you all made assumptions on the last test that the administrative assistant sits all day. There's no indication that we don't know what she did all day. Some of you made assumptions because I worked at a assembly company that I stood on my feet all day. You don't know that unless I say that, right? You don't know I could be an accountant working there. Some of you assumed that when I went on my tropical vacation, I went and got a bunch of sun. Last test. The right answer to that was stress can exacerbate this disease, and lupus, a sign of exacerbation is fever. And some of you all said your butterfly, your fever probably came from you being exposed to a lot of sun this past week. Tropical vacation for her might have been sitting in an air conditioning condo all week.
I think because she was with a bunch of friends.
Friends, yep.
She
And
was,
thought
but they
maybe
all
the
could have
friends
been
were
sitting in a con. She did say,
Too many people.
I love like the beach, I love being all that sunshine. that's what I've been doing on my tropical vacation, laying out the sun. I said, this patient did not say that that's what she was doing on tropical vacation. So sometimes assumptions are made, maybe the administrative assistant, the student said, I thought, figured they probably just said it here. Yeah, but we know some administrative assistants who are running around like crazy people all day long. And that patient did not say, I get so tired of sitting at my desk all day, or I get so tired of being on my feet all day assembling this part, or I love laying out in the sun, we had great weather, we were out on the beach all of my day. So, if we don't have that information, we can't make assumptions on that, right?
So what'd you say the correct answer was?
The correct answer was two facts, fever, sign of exacerbation, fact, and stress can exacerbate that. Fact and fact, I'm taking that answer, and I'm not gonna get straight off and talk into something else. And no, it's not tricky. It's just discriminating and kind of taking out things. Okay, everybody clear on that? I digress. Risk factors, being female. Aging. That's a lot of years for age, by the way, is 65 and older. If you pick anything less than that, you've got 50 points deducted from your test. Personal history, breast cancer in one breast greatly increases the risk of cancer in the other breast. Sometimes that's a conversation that they'll have with the patient. Yes, you only have breast cancer in one breast, but we really want to remove both of them so we don't take a chance that it's going to come back in your other breast. First degree relatives, everybody's clear on that. Grandma doesn't count, Aunt Susie doesn't count, nieces don't count. BRCA 1, BRCA 2, BRCA means breast cancer. That's an easy one to figure out then, the lab significance of that. Sometimes if patients are at high risk, they can be approved to get BRCA 1 and BRCA 2 mutations identified with getting that test approved. It's a gene mutation. When the cells are not acting correctly, the genes are not acting correctly, normally in normal cells, that is supposed to identify when growth is not needed, and that's not the case when we've got BRCA 1 and BRCA 2.
And then it was dark.
Again, as we talked about, either early onset of menstrual periods or late menopause. That means a lifetime of additional menstrual periods more so than the average female has. Tally them up. Same for no full-time pregnancies, and late age of first term pregnancy being the age of 30 or after. And again, you all can argue and say, well, they can still have their first baby at age 35 and still have 5 kids before they are done having kids. Yes, but just stick to the facts. If I say, here's the patient profile, identify her risk factors, just tally them up, look for that, and she says, well, my first child was born when I was age 35. Yep, you have a risk factor for that, and then just keep it at that, without going out there other places. Hormone therapy use is an increased risk factor as well. Exposure to radiation, especially to the chest area, especially if it occurred whenever the patient was going through their formative years when they were developing their breast. That only makes sense, because that breast tissue was scarred, especially when it maybe was at a vulnerable point, where it was the 12-year-old that had some kind of disease issue where they did radiation to her chest. It scarred the breast tissue right from growing up years. It is, but maybe you had radiation to your chest wall for a reason that wasn't cancerous, and that scarred your tissue, which therefore increased your risk of having breast cancer older. Why do you go there every time? Yes, I was giving a hard time. Good thinking, yeah, your brain is thinking exactly right. Because radiation scars the tissue wherever it is. So you're exactly right, I was just teasing you a hard time, for sure. quality to have as nurses, because you all are critically thinking through all of those possibilities for all the different immediate situations we come into. I was just giving you a hard time. Good thinking. Again, a history of hyperplasia, LCIS, cells acting abnormally, obesity, the way that fat is deposited, more fat tissue, increases estrogen levels, increasing the risk. And I'm only looking at my laptop. Last time I talked about this, a student goes, "You look straight at me when you said that." I'm like, no, I did not. I want to look up and he goes. Okay, high fat diet.
Oh, shoot.
Oh, do something.
Oh, shit.
Consuming 2 to 5 drinks per day.
Oh, shit.
And again, we can have conversation like, well, does that mean 3 light beers? Does it mean 5 drinks of liquor?
What if they drink a whole bottle?
I know, all of that.
A whole bottle in the.
But if you're looking at a patient profile in a few weeks from now, and she says, I like to drink 3 beers a day, it counts. I have 4 glasses of wine every day, that's a risk factor.
What if they only drink the weekend, but it's like
Oh my
a
God.
bottle of like.
And you're exactly
Because
right
a lot
about
of
all
people
that.
just do
Yeah, I
that.
don't
Like,
drink through the week, but I drink 10 whiskeys on Saturday night. Well, yeah.
Great thing.
Yes. But I guess if you were actually tallying it up, you would just do that average, right? Okay, you need 10 drinks on Saturday and Friday nights, but you don't drink anything through the week, that still is 20 drinks, or 10, whatever.
how do, if they're real
And you're
drunk,
gonna tally
how
up
do they
the
keep
working
track?
research lab, you certainly would say, well, then that's gonna be 10 drinks divided by 7 days a week. Or the potency of it, alcohol content, all that stuff. If you're actually doing that for a research study, you wanna definitely document all of that. So for the sake of you trying to identify risk factors, that's the numbers that we go with. This kind of makes me crazy because I'm going through that too. It's like, well, beer is a lot different than you drinking gin or whiskey or something else. That's probably a level of alcohol.
I don't count one.
To an aside to that, oftentimes patients will underreport what they drink, right? Well, I'm a social drinker, I'll drink a little bit.
I shouldn't be
I'll drink a
drinking
little bit.
because I get more hungry.
I know, every night, what's a little bit, how often you go out. That thing that says there were social drinkers just kind of makes me a little bit crazy. Because I'm like, okay, tell me what that means. Is that like a 6-pack a night? Is that, how social are you? I know, I don't think I should be allowed to how they talk to me. Social drinker.
I was like,
Drinks, 3 beers a night. All year round, whatever. Okay. Treatment for high risk. So you identified risk and you determined this patient's got several risk factors. Maybe you don't have cancer, no, but we do have identified that you have multiple risk factors. So we may recommend just close surveillance. We can recommend chemo prevention, as the word says. We're trying to prevent you from even having cancer. We can recommend you having a prophylactic mastectomy. And the first time I think that I can kind of remember in recent years, Sharon Osborne spoke to that. She had BRCA1, BRCA2 gene mutation, and she said, I'm signing up for surgery, I'm having a double mastectomy because I'm not taking a chance that this is going to develop into cancer. And she was pretty open about that and had a lot of community awareness about that decision. She said it's a no-brainer. Because I thought, you're going to tell me I have a really high risk of having breast cancer, why would I not have a double mastectomy? Not so easy decision to make for some people though. Sometimes it hits me, well, I don't think we're gonna do that, I'm just gonna wait and see how things go. And we have to kind of respect that. Breast cancer, it's irregular, star-shaped, fixed, usually not tender, typically in the upper outer quadrant. More advanced, you get that skin dimpling because all those ducts are involved. You are reviewing a patient's mammogram. You suspect that The finding is cancerous based on which characteristics? Yep, all of those things. So, I just made that question up. Okay, myself.
Did she say star shape?
Put it on the test,
She said star shape.
and the answer could be any of all these. Select all
Oh,
those
it
five.
do look
There
like a
you
little
go.
star.
Start thinking about that. No, I was kidding, all
But
questions.
we don't read x-rays, so we shouldn't read.
Lots of treatments, as we tell our patients, one size doesn't fit all, there's lots of combinations, there's lots and lots of ways that we treat that, and a lot of it depends on you individually.
So, why would say that, like, what is it in what is using a total mastectomy beside over, modified radical mastectomy?
Because it's right to the month.
Oftentimes they won't choose that, it depends on how well fit in it is. Like modified radical is. It removes a bunch, as you can see. If the patient, there will be a question about this one. If the patient has ALND, which means they dissected the lymph nodes, your job as the nurse is to preserve and make sure that the lymph circulation continues and does well. And I'll get to that in more couple slides. But this is whenever it involves lymph node dissection in addition to a mastectomy. Again, there's different options for patients. You don't need to differentiate between this one and the next one and the next one, because we could be here all day talking about the differences between them. This is when they do a node biopsy, testing for cancer. We can do a lumpectomy. One of my relatives' sisters got diagnosed with cancer a few weeks ago. She's 31. Strong history of cancer in the family, and they said, well, we could do a lumpectomy, but it'd be a great big crater that we would have to dig out, and your breast would not look right anyways. I mean, half of your breast would kind of not look right and you have a strong history. Her mother died when her mother was quite young, and she said, given you have BRCA1, BRCA2, and you said a lumpectomy is gonna make the breast look awful anyways, I'm just gonna have you just do the mastectomy and be done with it. Versus trying to carve out, leave half the tear, have a big crater, I might as well just do a mastectomy and be on the safe side. So there's some decision making that has to occur with all of those things. Your patient following a mastectomy, this is circled in red for a reason, will probably most likely go home with a Jackson-Pratt drain. You will need to go home with that. You have a caregiver that in mind, identify who's going to help you take care of your Jackson-Pratt. If you do, it would be helpful if they could come in and you can watch them drain that, such a ball back in place. Would like them to do that today versus me doing it for you, so they can for sure have some practice doing that. I'll send you home with some instructions on how to do that for your caregiver. And they'll probably be in for a couple of weeks. I need you to record the drainage that you drain from it every time you drain it, and when the drainage is less than 30 milliliters an hour, in a 24 to 48 hour time period, we'll take that out. You are educating your patient on how to care for his Jackson-Pratt drain following her mastectomy. What information would you give to her? That. Or you've given your patient education about the Jackson-Pratt drain, which statement means that they need more education, further education, and you're looking for the wrong statement. And some of you all have missed points because you've not got that straight around in your brain. So pause for a little bit. The question is asking, which of the statement means, I say to you, well, mom's Jackson-Pratt's gonna come out when it's less than 30 milliliters and 24 48 hour period, and you're like, request gonna be in for 6 weeks, and you're gonna be like, no, I need to fix that one. So pay attention to that verbiage. Again, send your patient home with instructions. If possible, try to have them do that while you're watching them, helping them. Refrain from doing that for them. I'm gonna let you do it. I'll walk you all the way through it to make sure that you know how to do it. Here are the printed out instructions. Here's my phone number. Here's a tablet of paper for you to write down, literally, how many milliliters you got out each time that you drank it. A tablet of paper, I should say, a tablet. I told my grandson the other day something about, oh, I got you a tablet. You bought me a tablet? I meant like a $2 like Walmart paper tablet. I didn't mean like a, sorry to disappoint you, kid, but. Okay, so the patient has had an axillary lymph node dissection. We're concerned about their lymph circulation. You can prevent lymphedema. You can prevent lymphedema. It's a hazard, it's a complication that goes with an ALND surgery. As indicated, look at this patient's arm on the right arm there. As indicated by painful swelling, tingling, all indications of decreased circulation. You can prevent lymphedema. Elevate that arm. Teach your patient to take good care of that arm, including any of the following. Those are just pretty much common sense.
So, if they have double mastectomy, they need to do everything outside?
Just be reasonable. That would mean like blood pressures and stuff like that. You just have to take it. Or do it on a leg or something. I know, it's always a fine line between that. I know, right? So you're the post-op nurse taking care of this patient following ALND surgery. You know what, I'm gonna make sure that your arm stays elevated because I wanna promote that circulation. I'm gonna have you do softball sponge squeezes in the recovery room. I wanna get that circulation moving right off the bat. So you're the recovery room nurse. She's in there recovering and you're gonna get her a sponge ball and I'm gonna say, I'm gonna have you squeeze this. I want you to just keep circulating. I'm gonna have you elevate your arm. We're not gonna do any blood pressure. We're gonna put this armband on and say no blood pressures, injections, nothing in that arm. I'm gonna try to prevent you from getting lymphedema.
So no sunscreen or?
Oh, you can put sunscreen on. That would probably be a good idea. I don't want you getting that arm sunburn either. Good question. So it'll be definitely either your management of that as her nurse, or you're educating your patient as her nurse. Hematoma is another post-op complication. Hematoma is a collection of blood. Again, bruising. Notify the surgeon immediately. Gross swelling. Increased blood in the JP drain. If a patient has a hematoma, if able, I sometimes will take a pen and I'll circle the outside of the hematoma and put the date and time on it. That way you as a nurse can see if it's going like this or not. Did you have a comment or question?
Yeah. So if they do not have the lymph nodes removed, they just have the mastectomy without the lymph node removal, are they still at risk for this lymphedema?
I suppose they could be, but it's probably not very likely.
Okay, it's only
You haven't
when
really
that's
messed with the lymph circulation.
usually when that's removed. Okay.
Yeah, good question. Questions about lymphedema, management of that as a recovery nurse, management of that as a patient, management of the hematoma, which are post-op complications. Anybody have questions about any of those? Okay, this is gonna be important for you to kind of get figured out in your brain. 2/3 of breast cancers depend on estrogen for their growth. They thrive on estrogen feed. So the cancers are growing because the estrogen keeps feeding into it. So our goal for part of your treatment for your breast cancer therefore, is to stop the estrogen feed. They call those kinds of cancers ER positive. Estrogen receptive positive. When it's an ER positive breast cancer, it thrives off the estrogen feed. That's what that means, ER positive breast cancer. So our medications are going to be designed to stop the estrogen feed. This is important to know. If you are premenopausal, we're going to stop the estrogen feed. The drug of choice, the category of choice, are called SERMs. As it says, estrogen modulators, stops the estrogen feed. And for the premenopausal female, tamoxifen is the med of choice. It stops the estrogen feed, therefore stopping the tumor growth. Because I stop the estrogen feed, the side effects are going to be menopausal side effects, right? So I'm stopping the estrogen feed. Better describe it here. Common side effects are menopausal symptoms.
What was SCRM stand for again? Selective?
Selective estrogen modulator. There you go. Receptor modulator. ER positive means that it thrives off of estrogen. I'm going to give you medication to stop the estrogen feed, and the category is called this, which is going to change the way the estrogen gets received. However, with that, because I'm decreasing your estrogen, you're going to have menopausal side effects. This whole, menopause is a decrease in your estrogen as a female. And I'm going to decrease your estrogen to treat your cancer, then you're going to have menopausal things that occur. You guys good with Okay, as I said, there's menopausal, there's always adverse effects, right? We talked about how that's different than side effects. Because I'm stopping your estrogen feed, think through that with me for a bit. It's a premenopausal female, so she's 40. She got diagnosed with an ER positive breast cancer, which is the cancer that feeds off your estrogen. I'm going to recommend for you to take tamoxifen. Because I'm decreasing your estrogen levels, you're going to have menopausal symptoms, side effects, most likely. And if I stop the estrogen feed, estrogen is what's responsible for you to look and appear female, right? That's what makes you look, have the female characteristics. If I'm stopping your estrogen feed, what are some other side effects that you may have? Correct, more male-like characteristics. The estrogen is what helps you look female, all you females out there. So if I stop your estrogen feed, because I'm treating your cancer, you also may have male-like characteristics. Facial hair growth, decrease in things that make you look female. Does that make sense? Okay, different patient. This patient has an ER positive breast cancer. It feeds off of estrogen, but she is postmenopausal. And just the way it's designed, the way that estrogen works within her body, these are better drug choices for her. They're called aromatase inhibitors. And as you can see, some of the primary ones end in ZOLE, Z-O-L-E. And I just kind of do from A to Z. So I just do aromatase inhibitors in my brain, and then an example of that are the ZOLEs. They both have the same kind of cancer. She ended up 40-year-old have both had ER-positive breast cancers. Those cancers fed off of estrogen. The premenopausal female, her tamoxifen works better for her by design. The postmenopausal female, this group of meds works better for her. They both are gonna stop the estrogen feed. They're both gonna have similar side effects because of the stoppage of estrogen feed. Is that clear in your brains?
So what's the age group on that?
What's that?
What was the age group on that?
Postmenopausal. If you're given that scenario, in a few weeks, you'll definitely have, you won't have a 51-year-old. Because it's like, where do they fall into that group? It'll either say she's postmenopausal, or it'll say she's 62, or it'll say she's 40. So you won't have an in-between age. Okay, let me think. You said she's 40, ER-positive breast cancer, and the question is, what kind of medication do you expect to be prescribed for her? Okay, she's premenopausal, she's got ER-positive breast cancer, I'm looking for that medication that we talked about in class that works for her. Or I'll give you an age group that's definitely postmenopausal. After 60-ish, correct. I won't give you that 50-some-year-old because I have no idea. Or I'll tell you point blank, she's premenopausal or she's postmenopausal.
So tamoxifen is premenopausal and, the other three are post.
Yes.
Oh, okay.
Yep. Similar side effects, again, as we talked about, it would be menopausal side effects because you're taking away the estrogen feed for both of those ages of people. Targeted, there's lots of other therapies, I'm not gonna spend time talking about them. Targeted is great because it doesn't have so many systemic side effects to them. After the patient has had a mastectomy, and so they remove the breast, so it's a flat chest wall, right? Because the breasts have been removed. So the patient has to go through a tissue expansion process. Because there's not gonna be a place to tuck in the implant if you don't expand the tissue there. Because the tissue is flat on the chest because the breasts have been removed, right? So every few weeks, the patient goes in, they have a metal implant port put in, and they'll go in there and they'll inject saline to keep expanding that breast tissue, that chest tissue. Because you're not gonna have any room to tuck an implant in if you are dealing with a flat chest wall. So they go through an expansion process. What you need to know as a nurse is that port contains metal. So they'll put the metal port in, and I'll say, I'm gonna have you come back every week or every couple of weeks, and we're gonna keep expanding your chest tissue, so I have room to tuck the implant in. But while you have that metal port in, you cannot have any MRIs done. The expansion process has been done. They figured out how much they need to stretch the skin, what size the breast the patient wants. Sometimes they can pick for themselves how big they want their breast to be. You're ready for your implant today. We're gonna take your metal port out, and then you're gonna get your implant in. So while the expansion process is taking place, you're gonna have a metal port and you can have no MRIs. After you got your implant, you're not gonna have a metal port anymore because it's not needed. Does that make sense?
Is it still along the same thing with metal detectors for airports and stuff like that?
Correct.
Do they give her a little card to carry?
Yes. Are you guys okay if we just go till 10 till 2 and not take a break here? You guys?
I wanted to.
Okay. Well, that'll be the game plan. You know, you can always get up and take a break if you need to. If it's appropriate for your patient, sometimes they can create the breast tissue out of an abdominal tissue. So, you know, what's cool about that is there's less chance of rejection. The biopsy matter is taken from the patient from another spot, right? And the bad part is you've got several incisions now that abdominal incision, you're dealing with a breast incision, and pretty soon the patient's got a lot of recovery going on. As I said, as we talk about oncology, not all things are appropriate for all patients. Just because your friend had this done doesn't mean that you're a candidate for that because of these reasons. Tissue transfer, we'll take it out of one place, reconstruct the breast out of another one. The nice part about that is the breast will change, the reconstructed breast will change as the patient's weight changes. So we'll get bigger when they gain weight, it'll get smaller when they lose weight because it's natural tissue. And they'll also get droopy over time. Another point of that, so your patient's gone a mastectomy, they've gone through the expansion process, which means they've injected saline in till the tissue has expanded enough so we have enough room to put an implant in or reconstruct the breast. We can also do nipple areola reconstruction. So the patient can pick kind of how they want that to look, what color, they want it 3D, how they want it to appear. So it's nice the patient has some choices in some of these treatment plans. And sometimes patients don't want to have reconstruction done at all. I don't want to have to go through that. It's not important to me. They sell great swimsuits and bras now that have one side that is got some additional material on it, looks like breasts. So there's things that people can buy to make themselves look like they have breasts even if they don't. So again, there's lots of choices the patient can make. We're at a Christmas party, it's been years ago, and I had an aunt that the more she's longer she's up at Christmas party, the more alcohol that gets consumed, and the more just like the stories start without filters. And then she told us all about this process that she went through, how she could pick out any color she wanted. Like, oh my gosh, it's cool. And they brought out my colors, and I thought, I just want mine with. I'm like, oh my gosh, you're at a Christmas party, and there's like 80 of us here. So, but it is cool because you do get choices. They can tattoo them nipples on, they can make them different sizes, different colors, different ways to look. So patients can have lots of choices when it gets to this point, how they would like that to be, how they want that to appear, all that is for them, and from a medical standpoint also. Okay, reduction mammoplasty is when we reduce the size of the breast, and then they'll probably have a JP drain in. Breast augmentation is when they put that implant in. It's important to know the difference between the two types of implants. Saline, if a saline implant leaks, the body can absorb it. If a silicone implant leaks, the body cannot absorb it. And if you read information, there's reasons why people pick one versus the other. But if you have a silicone one, be aware that your body won't absorb the leak, and they recommend you getting MRIs to see if it's leaked or not, but insurance probably will not cover that. So you may have a leaking implant and not know it and not have an MRI to figure that out. Just because you have an implant in, you still have to do self-exams, you still have to do clinical breast exams, you still have to have mammograms, but they're not as conclusive because you've got that extra implant tissue in there. So yes, you still have to have your mammogram, but they're hard to read because you have an implant in there. When my daughter graduated from high school, breast implants was in the top 10 graduation gifts from their parents.
This was the top 10 for her.
I'm like, yeah, you're the last one for that tax. Yeah, I think, oh my gosh, I think that. Trying to think my opinion about that, but I'm like, none of this house, I don't think. Mastoplexy is just an improvement in lift if the patient.
That's what I was thinking about.
Questions about any of the breast conditions that we covered for females? Any Nipple discharge is probably the hallmark symptom that we see with male breast cancers. Often diagnosed late, why?
Because men don't get checked.
They don't get it checked out. I don't think that can happen to me, that's only a female problem. Yes, we can identify BRCA1, BRCA2 with males. BRCA is breast cancer, so that applies for males as well as females. Again, you can do a mastectomy, and ER positive tamoxifen is the drug of choice, without any age specifications necessarily for this one for males. Yes, you can get breast cancer as a male. Yes, you need to identify it, pay attention to it, report if you have any kind of lump that you've noted, because yes, you can get that as a male. And there's lots
Can
of
they-
alternative therapies.
So they can have a choice to get breast. Like if they get a mastectomy for men.
Okay, now we're finally on the males.
Well, I mean, if you already have.
Changes in the older population, as you're probably already aware of,
If you have the
maybe
gene
conversation
brackets.
with patients taking histories, there's models out there that you can
And if
use
you
and
like,
explore
do
and
your,
try
you
if
be
there's something that works good for you for a good
you know, they would take
consultation
advantage.
tool.
I would
Screening
buy
is important, screening is important. Age 50 and older. High risk, we deduct 5 years. Who's his first degree relatives?
Father.
Father, brother, son. African American also increases the risk. Digital rectal exam is palpation of the prostate. It's called a prostate. It's not called a prostrate. It's a prostate gland. Please don't pronounce that wrong.
What did she say? Prostate.
We do the digital rectal exam after the PSA. Testicular exam, again, how often do I have to do a testicular self-exam as a male? Monthly. How often do I have a testicular clinical exam?
Yearly.
Thank you. Don't mix those up.
After one
PSA
shot.
is a blood test where this is I think the only lab we've talked about today. The only lab you probably need to know today. I don't think we talked about any other ones. This one. Normal PSA should be under 4. You must do the PSA before the DRE. You must do the PSA before the DRE.
Under 4.
Because if you do the DRE first, you may have irritated the prostate and your PSA result is not going to be accurate. If you do the DRE first, you digitally manipulated the prostate exam when you examined it, you may alter the result of the lab test. Lab test has got to come first, then the DRE. Both of these are considered to be the screening tools that we use for the males. A normal PSA should be under 4. Just because you have an elevated PSA does not mean you have cancer. There's lots of reasons why you may have an elevated PSA. It's a lab test. We can do an ultrasound if we need to, if we need to evaluate things further. We can always do a biopsy. Following the biopsy, we put those patients on antibiotics because there's a high risk for an infection following the biopsy procedure, just by nature of the beast. Your semen may be red or rust colored for several weeks. Your prostate is what produces your semen. Because we've irritated your prostate, we may have indications of irritation within the semen as well. Don't get alarmed. This is Smiling Bob. You probably haven't met him. He was on a riding lawnmower with super cheesy music in a commercial, and he smiled because he had his male problems addressed. He was advertising a male enhancement product. But it was, I think, only until Bob was on his commercial that people started talking about erectile dysfunction. His male and sexual enhancement drug is no longer on the market. But thanks to him and that commercial, there was a lot more awareness of, yes, I had erectile dysfunction issues. And before that, it was pretty much a, it's like erectile dysfunction dysfunction, you have to deal with it yourself, and there wasn't no treatments really identified, and nobody ever talked about it. Lots of reasons why a patient may have an erectile dysfunction.
Stress.
Okay, we'll go through the meds a bit. Erectile dysfunction meds cannot be taken if your patient is taking a nitrate. You cannot take erectile dysfunction med if you are taking a nitrate, because that's a combination of vasodilator and vasodilator, too much vasodilation, low blood pressure. So you look through your patient's history, you see that he takes a nitrate, and he says, I'd like to start taking Viagra or Cialis, and you're gonna say, no, I'm afraid we can't give you anything like that. Safety, safety. Be watchful about patients when they wanna order erectile dysfunction meds off of the internet. $80 for a 1 month supply, not really tested, don't really know what the side effects are gonna be. Be cautious about being smart about those kind of purchases. There are lots of them out there. The recommendation typically is take them an hour before sexual activity. There are side effects, not with nitrates. You don't have to know the difference between those three. There's others on the market as well. What's in red is they do not have any effect on sex drive. They have an effect on functionality. They don't affect the sex drive. That's within your brain. Contraindications if you have heart problems. What these time frames mean is that the recommendation is to take an hour before sexual intercourse. The effects last up to 36 hours. It doesn't mean they're going to have an erection for 36 hours. It means that their penis is more prone to have an erection during that time frame. It increases the likelihood of that because of the increased blood flow to the penis. Any questions about erectile dysfunction meds? Yes, there'll be safety concerns that you'll need to know about that. It doesn't change the sex drive. You still need to protect against sexually transmitted infections. That doesn't change. Can't take it with a nitrate. Take an hour before the anticipated sexual intercourse. The effects have varying lengths of time that increases the likelihood of them maintaining and having an erection. There's also penile implants that they can put in and insert. Sometimes we have patients that are like paraplegics, and some of them, but that's a good option for them. You can put in rods. There's lots of other options for patients that are having trouble with erectile dysfunction. Usually we don't reconstruct penises unless there's been a trauma to them. We have vacuum devices. And again, alternative therapies and herbs might be some options. As well as identifying if there's any identified cause of them having erectile dysfunction. Premature ejaculation, again, identifying the cause for that. Retrograde means that the semen travels backwards. No more, no less about that unless you have questions about that. I'm kind of cruising through them fast because I'm not going to spend a long time on them. Inflammation of the prostate, as the word says. Antibiotics, anti-inflammatories. We can also teach patients to do, male patients to do Kegels. It improves the blood flow to the sex organs. BPH, enlarged prostate. You do need to know that with BPH because we see that fairly commonly. The prostate's enlarged, pushes up against the bladder outlet, the ureters, and it causes urinary problems. That prostate is enlarged by the way it's located, it presses up against the urinary tract, and responds to. And that's typically the presenting symptoms your patients will come in with. They won't know they have a large prostate. For some reason, I've been having trouble, I get up and urinate a lot of times through the night, I'm having trouble getting, I don't put much urine out every time I go, and then you're the healthcare provider, you're like, oh, we should probably test your prostate, because it may be enlarged, which means it's pressing up against your ureter and not allowing you to outflow urine. So that's gonna be your primary assessment for somebody that you suspect has BPH. Let's do a avoiding diary, see what kind of issues you're having with your urinary stream. It depends on how much things are changed, how much impactful it is. Do a PSA before you do your DRE. We can do ultrasound and stuff like that. Okay, this part is important to know. A lot of times we will put them on two different types of medication. One medication will help your urine outflow. These. They end in SIN. They'll work within a couple days. One's called Flomax. I love the name of that.
Didn't I just say that?
It does not change the size of your prostate. This is a fix for your urinary stream. It does not change the size of your prostate. But this will help your urine outflow. There are side effects. The second medication I'm going to prescribe to you reduces the size of your prostate. Those end in RIDE. STERIDE. It will take some months until it reduces the size of your prostate. That's why I'm giving you two different medications. One doesn't do what the other one does.
So why would they give one versus the other?
They give them both. I'm going to improve your urine flow within the next couple of days by giving you this one. And I'm going to reduce the size of your prostate over time by giving you this one. I'm giving you two medications. Could you educate your patient on which does what? I'm giving you one to improve your urine outflow. It's going to work pretty quickly. I'm going to one to reduce your prostate, because that's what's causing the problems anyways. It's going to take some time, like months, until it gets your prostate reduced.
You can cause a UTI through urine. The urinary retention. So that's why it's probably working.
There are some that do both of those functions. One's called Jalen, it does both of those. But somebody that was in here last semester said she worked in an office where they prescribed stuff for this a lot, and said insurance wouldn't pay for the combo med. They would pay for two separate meds, but not the combo one. Because it's too new, I guess. Oh my gosh, I don't know where the day went today. Alternative therapy is always an option. Teaching your patients management of BPH, frequent sexual intercourse that helps drain and empty the prostate.
So have a
That's probably one of the things that I would kind of make note of that one. We can do other treatments as well. We do therapy to reduce the size of the prostate. You can always put in a stent that keeps vessels open.
to get rid of.
We can do a TURP, which goes in the end of the penis, breaks up the prostate and pulls out the pieces of the prostate through that instrument. There's no incision, the instrument goes in the penis, breaks up the prostate gland, and removes it through that instrument. They may have temporary dribbling. We can do laser surgery. Cancer of the prostate. I'll try to cruise through your fast. I know before that's a shower 10 tell. Most common, these are the risk factors for prostate cancer. Older population, African Americans. Older population, African Americans, prostate. And we already talked about family history, BRCA1, BRCA2. Again, the symptoms will be the urinary symptoms. The prostate produces your semen, so the patient may report blood in the semen. Sexual dysfunction, painful intercourse during ejaculation, because that's when the prostate's emitting the semen. Gross hematuria is a late sign. So that means that it's majorly impacted the urinary system. Early detection, cure rates high. Early detection as in your screenings, your PSA, your DRE, and ultrasound if needed. Again, monitoring for bleeding if you're doing biopsies, things like that. That's just pretty much common sense. Don't write those down. 93% of the circulating testosterone is testicular in nature. So we're gonna stop the androgen feed for these prostate cancer patients. That only makes sense. Prostate cancer feeds off of androgen. Androgen is what makes you appear male when you're a male. We're gonna stop the androgen feed. These are the meds that are typically used. Anti-androgens, you can see that they end in MIDE. If I'm giving you an anti-androgen, what's going to happen with that person's male sex characteristics?
Decrease.
Correct. So why decrease? If you have a decrease in your male sex characteristics, what kind of things might you develop as side effects?
Less
Correct.
hair.
Female-like stuff. Correct. So, I'm stopping the hormone feed because you have prostate cancer by giving you those medications. I'm taking away the androgen feed. Therefore, they're going to have menopausal symptoms, and they're going to have more female-like characteristics. We can do prostatectomies. There's a vaccine they're attempting to figure out whether that works or not for treatment of prostate cancer. Transurethral resection is what it says it is. We can go through the urethra and we can resect it. There's all kind of little cartoony things and stuff that you can look up and do. For the TURP procedure, we'll put fluids in, irrigate it out afterwards. I'm not spending any time on that. This one you do need to know though. Transurethral resection syndrome. So you've done that procedure, you've resected the prostate, removed it out, and there are complications that go with that one. As you can see, a lot of them are neuro-related problems. Convulsions, visual disturbances, confusion, seizures. Heart rate goes up, the same reason we talked about all along. Blood pressure goes down, the same reason that we talked about also. One side effect is low sodium. We talked about that earlier as well. Although the transurethral resection syndrome is rare, it still is potentially life-threatening. Because of the amount of solution they use to irrigate it while they're doing the procedure is what causes the problems. They use a lot of fluid in there to irrigate while they're resecting the prostate, and therefore it just messes the electrolytes and all that up. May develop low sodium levels. We may give them diuretics, which makes sense. Take those extra fluids out of there. Again, categorizing the symptoms, a lot of times they're neural related. Several approaches to prostate surgeries. The prostate's very vascular, so postoperatively, what is your concern? Of course, yep. Questions about prostate management? Go ahead. I know. know that they're anti-androgens, what would they do? They would decrease the hormone P, and then what side effects go with that? Okay, this is an inflammation of the testes. ORCHI means testicles or testes. It's rare, I'm not spending time on it. This is inflammation of the epididymis, I'm not spending time on that one either. Testicular torsion is the blood vessels get twisted on themselves. It's an emergency, you cut off the circulation to the testicles. Torsion, that's what that means. Testicular cancer, different spectrum than the prostate. Prostate was older patients and African American. Testicular is younger patients and Caucasians. What does cryptorchidism mean?
That's when it doesn't descend.
Correct. The boy is born and his testicles are not in the scrotal sac. So that creates an increased risk for him as an adult, even right from the beginning. Because the testicles were not in the scrotal sac, they already were damaged right off the bat. So that's a risk factor. Younger, childbearing years, younger, and Caucasians. So different than the prostate cancer. Early detection is important. The patient will oftentimes present with a painless lump in their testicles. If they're doing their testicular self-exams once a month, after a warm shower, when the testicles are most relaxed. It's the best time to do your testicular cancer exam, your self-exam, which is once a month. One of the most curable of tumors. Again, it's a painless lump, is a presenting symptom. Those are the ages here, childbearing years. If any of you know Lance Armstrong, who was the bicycle rider, he had testicular cancer. He's a typical picture of a patient with testicular cancer. Caucasian, and he was within that age group. And I remember it's a painless lump because I think if he had a painful lump, he couldn't ride his bicycle. I don't know what, but it's a painless lump in the testicles is what the presenting symptom is. Scott Hamilton was an ice skater from years back. He also kept a picture of a patient that would have that. Orchiectomy is removal of the testicles, taking care of the cervical site. Hydrocele, you'll probably learn more about that in the next or OB next semester. In red and bold, phimosis is when the foreskin can't be replaced to its usual position. So you've retracted the foreskin because you're catheterizing the patient, you retract the foreskin because you're washing the patient, you've got to put the foreskin back. If you don't, you've created a constriction on a rubber band on the penis. So if you have retracted the foreskin for either of those nursing activities, you've got to make a point to put the foreskin back. Otherwise, you've constricted the penis like the picture shows. I think this was the picture that I had on when the guy came in and fixed the ceiling. He comes in, opens the door, and he goes, back at lunch.
It was probably painful.
His eyes on this
Yeah.
around.
That's crazy.
I think I'm like this.
Probably like, oh my God.
Okay, penile cancer is rare. I'm not going to cover that as well. Priapism is important. It's an erection that lasts longer than how long? What did I say? 4 hours. Because you have this increase in blood flow to the penis for that amount of time, you could cause little or no blood flow because it's super congested. So yes, the erectile dysfunction meds work well for conditions. However, One of the hazards is you could have a persistent erection that doesn't go away then. It is an emergency if it lasts more than 4 hours. Peyronie's disease is when the penis is curved. You probably have seen the commercials. They show a banana on the start of the commercial. You can have strictures, circumcisions. You're going to